Imagine treating a purely structural, mechanical failure of the human body, like, say, a leaky bladder or an actively degrading pelvic floor, not with a scalpel.
Right, and not by surgically implanting some kind of synthetic plastic mesh, which we know has its own issues.
Exactly. Imagine treating it by just shining a completely invisible beam of light into the body to rapidly boil microscopic pockets of water.
It sounds entirely counterintuitive when you phrase it that way. I mean, we are so conditioned to think of structural medical problems as requiring purely mechanical solutions, you know?
Right, like if you have a sagging support wall, you brace it with something solid.
Exactly.
But the data we are looking at today flips that entire paradigm upside down. Welcome to the deep dive.
Glad to be here. We have a massive stack of clinical studies, histological reviews, and preclinical trials to guide us through this one.
Yeah, we are exploring a really profound shift in how we approach internal tissue repair. Specifically, our mission today is to unpack the exact mechanism of action of fractional CO2 lasers on the sub-urethral vaginal wall fascia.
Which is a huge topic right now for treating conditions like stress, urinary incontinence, or SUI, and genitourinary syndrome of menopause.
So for anyone who has ever wondered how doctors tackle these complex structural issues without using meshes or synthetic implants, this deep dive is absolutely for you. We are going to trace the journey of a laser beam from just a physical light wave down to the literal molecular transformation of human collagen.
It's honestly fascinating how it works.
Okay, let's unpack this.
Yeah.
Before we can understand how the fascia actually changes, we have to look at the physics of the tool itself, the microsculptor.
Right, so the tool driving this specific tissue regeneration is a microablative fractional carbon dioxide laser. And the defining metric here is its operating wavelength.
Which sits at exactly 10,600 nanometers.
Exactly, 10,600 nanometers, which is completely invisible to the human eye. It rests deep in the infrared spectrum.
And that specific number, the 10,600, is the key to this entire process because of how it interacts with the local environment, because the vaginal mucosal tissues are incredibly water-rich.
Highly hydrated, yes.
So when the specific wavelength hits the tissue, it is highly absorbed by that intracellular water.
Right. We call this targeting a chromophore. A chromophore is just, it's the specific molecule in the tissue that absorbs a particular wavelength of light.
Kind of like a dog whistle.
That is a perfect way to look at it. A dog whistle operates at a frequency tuned so perfectly that only the dog hears it, and it just leaves the rest of the environment totally undisturbed.
So the 10,600 nanometer wavelength is essentially a dog whistle for H2O.
Exactly. When the light hits the tissue, the water molecules absorb that energy and instantly convert it into thermal energy, just pure heat.
Intense, highly localized heat. But, I mean, blasting the entire vaginal wall with a solid wall of heat would just cause a massive traumatic burn.
Which is the last thing you want.
Right. So that brings us to the fractional part of the laser's name, which fundamentally changes how this energy is actually delivered to the tissue.
Yeah, the laser uses a grid-like scanner to break the beam up into hundreds of evenly spaced microscopic columns of thermal injury.
It essentially punches tiny dots into the tissue, penetrating down to a depth of about, 500 to 1,000 micrometers?
Yes, 500 to 1,000 micrometers. And that depth is critical. It bypasses those surface layers and delivers the energy directly into the deep connective tissue, the lamina propria.
But it doesn't hit everything in its path.
No.
Yeah.
And what makes this viable internally is what happens between those dots. The laser leaves the intervening tissue completely untouched and healthy.
You know, this sounds exactly like aerating a lawn.
Oh, that's a great analogy.
Like when your soil is hopelessly compacted and the root system is dying, you don't rent a bulldozer and tear up the entire yard.
No, you destroy the grass.
Right, you take an aerator and punch tiny strategic holes deep into the dirt to stimulate the roots. And you basically rely on the healthy grass directly adjacent to those microscopic holes to do the heavy lifting and speed up the recovery.
What's fascinating here is that this exact grid pattern is what minimizes the epidermal injury almost entirely. The patient experiences virtually no downtime because the surface architecture remains largely intact.
But it's still doing the work underneath.
Exactly. It still manages to deliver a profound thermal shock deep into the dermis, which is where the structural support actually lives.
Okay, so we have these microscopic columns of light firing into the lamina propria. The physics of the light instantly gives way to the biology of the tissue.
The transition from physics to biology, right?
Yeah. And within that 500 to 1,000 micrometer depth, the heat rapidly boils the intracellular water. The clinical data describes this as a photothermal effect.
Yes, and the primary target of this photothermal effect is collagen. Healthy collagen acts as the primary scaffolding of the body. It maintains this incredibly rigid, stable, triple helix structure.
I always picture it like a tightly wound, microscopic steel cable.
That's exactly what it looks like. But as estrogen drops during menopause, that collagen degrades. The tight cable loses its tension, and it becomes really weak and disorganized.
Okay, wait, hold on. If the problem is that this tissue is already thinning and degrading, and the collagen is already weak, why are we firing a laser to essentially burn and destroy what little support structure is left?
It seems backwards, I know.
Yeah, I mean, boiling cellular water and breaking down the triple helix sounds like we are intentionally making a fragile structure even weaker. Why is localized destruction a good thing here?
This raises an important question, and it really gets to the very core of how regenerative medicine operates. You have to look at the Joule effect and the principle of selective photothermolysis.
Okay, what does that mean in this context?
The localized destruction you are asking about acts as a necessary distress flare.
A distress flare, because the body doesn't realize there's a problem.
Precisely. The atrophy of the vaginal wall is a very slow, gradual sagging. There are no biological alarms going off.
Oh, I see. So the body just thinks everything is fine.
Right. The body's immune and repair systems essentially ignore this degraded collagen because there is no acute crisis for them to respond to.
So the laser creates that crisis.
Yes. When that intense fractional heat pulses into the lamina propria, it instantly snaps the intermolecular crosslinks that stabilize that old dysfunctional triple helix. It denatures it.
So without creating that controlled microcrisis, the body will never send in the repair crew to build fresh, highly elastic tissue from scratch.
The tissue has to be shocked into remembering how to heal itself, and that physical snapping of the crosslinks causes an immediate mechanical reaction. The collagen fibrils instantly contract and shorten.
And the preclinical data on this is wild. It says a carbon dioxide laser causes about 15 to 25% immediate shrinkage of the tissue.
Yeah, that is vastly superior to other modalities. For context, an ERYAG laser only causes about 1 to 2% immediate shrinkage.
Wow, only 1 to 2%.
Yeah, the carbon dioxide laser is essentially taking that loose, stretched out rope and snapping it tight in a fraction of a second.
So you get this immediate physical tightening effect. But that thermal hit is also setting off the chemical distress flare we just talked about.
Exactly. The controlled heat shock provokes the cells into producing a very specific family of chaperone proteins called heat shock proteins, or HSPs.
In looking at the histological analysis, it points to a massive overexpression of HSP 43, 47, and 70 following the treatment.
Right, and HSP 47 is particularly crucial here. It locates itself in the rough endoplasmic reticulum of the cell.
The rough endoplasmic reticulum being the cell's manufacturing center for proteins, right?
Yes, the cellular assembly line. HSP 47 acts as a strict supervisor on that assembly line. It carefully chaperones the newly formed procollagen molecules, making sure they fold into the correct, tight triple helix structure before they are secreted out of the cell.
So without that heat shock protein flooding the area, the early stages of building new collagen simply stall out.
They do. The SOS flare has officially been fired. The body is fully aware of the microcrisis.
Which brings us to what the clinical literature calls the delayed biological response. Because, the immediate shrinkage happened in a millisecond, but the real structural overhaul, the long game, takes place over the next 30 to 90 days.
Yes, those heat shock proteins trigger a massive cascading release of highly specific growth factors into the surrounding tissue environment.
Here's where it gets really interesting. The data outlines this highly coordinated cellular construction site. And instead of getting bogged down in the massive alphabet soup of all the growth factors,
Because there are a lot of them.
there are so many. TGF-beta, BFGF, EGF, but looking closely, just 2 of them reveals exactly how this tissue transforms. You have VEGF and PDGF. VEGF is vascular endothelial growth factor.
Right, and VEGF is responsible for neoangiogenesis. It lays down the critical infrastructure.
The plumbing.
Exactly, the plumbing.
Because before you can bring in the construction workers to pour new concrete, you need a supply line. So VEGX stimulates the building of brand new blood capillaries to flood this previously atrophied, poorly oxygenated tissue with a fresh supply of oxygen and nutrients.
And once the plumbing is in place, PDGF, which is platelet-derived growth factor, sounds the alarm for the fibroblasts.
And the fibroblasts are the undisputed star players of connective tissue regeneration. They are the actual construction workers on site.
They really are. When they receive the signal from PDGF, they migrate straight to the lamina propria and immediately begin synthesizing a brand new extracellular matrix.
Yeah, the ex vivo studies where researchers actually put the post-treatment tissue under electron microscopes, they show that these fibroblasts aren't just furiously laying down rigid scar tissue.
No, they are engaging in highly targeted neocollagenesis and elastogenesis. They produce new elastin fibers and heavily synthesized type 3 collagen.
And type 3 collagen is fundamental to understanding this mechanism, right?
It is. We often refer to it as young or flexible collagen. It is the highly elastic structural protein that dominates the tissue prior to menopause.
But as the body ages and estrogen depletes, that type 3 gets slowly replaced by stiffer, far less functional variants.
Right, and the specific thermal profile of the carbon dioxide laser forces those fibroblasts to revert to their youthful programming, just pumping out that flexible, resilient variant again.
The macroscopic result of all this cellular labor is a complete restoration of the trabecular spatial architecture.
Which sounds complicated, but it's very structural.
Yeah, to visualize that term for you listening, imagine the crisscrossing steel beams inside a skyscraper. Over time, those internal beams had rusted, they thinned out and started bowing under the weight.
A great visual.
The laser treatment basically replaces them with brand new, thick, perfectly aligned steel girders, restoring that 3D scaffolding to a premenopausal state.
And alongside that structural steel, the tissue drastically increases its production of ground substance.
So things like hyaluronic acid and proteoglycans.
Exactly. Molecules that act like microscopic sponges. They pull massive amounts of water back into the extracellular matrix, restoring deep tissue hydration that had completely vanished during atrophy.
So to truly grasp how deeply this remodeling alters the tissue biomechanics, we should probably look at a highly specific cohort that was studied in the clinical trials, breast cancer survivors.
A uniquely vital group for this research.
Yeah, because many breast cancer treatments intentionally suppress or block estrogen entirely, throwing these women into a sudden, severe, medically induced menopause.
And they absolutely cannot utilize local estrogen creams to alleviate the resulting vaginal atrophy because of their cancer history.
Right, it's contraindicated. So for that population, finding a non-hormonal, purely mechanical solution for tissue regeneration is entirely life-changing.
It really is. Researchers took biopsies of the vaginal wall in this cohort before and after the fractional carbon dioxide laser treatments. And using digital image analysis to quantify the exact cellular changes, they documented an explosive increase in stromal elastin.
You remember the numbers on that?
Yeah, the baseline was sitting around 33%. After the laser therapy, it jumped to nearly 57%.
Wow, 57%. But the truly defining detail of that study was what happened on the surface level.
Right. The researchers noted that these massive structural improvements in the deep stroma, that massive jump in elastin and type 3 collagen, occurred even when the surface epithelium showed no obvious microscopic signs of regeneration under specific staining methods.
That is so wild. It proves that the true therapeutic mechanism of this laser isn't just a superficial polishing of the surface.
Not at all.
The magic happens deep in the connective scaffolding. The laser is fundamentally changing the tensile strength of the foundational wall, regardless of what the very top layer of cells is doing.
Which is exactly why this specific technology works as a functional cure for mechanical failures of the pelvic floor, rather than just, a cosmetic smoothing of the tissue.
Right. And that drives us directly into the anatomical payoff. We've tracked the physics of the infrared light, the millisecond of thermal shock, the snapping of the triple helix, and the weeks of cellular rebuilding driven by fibroblasts.
The whole journey.
Yeah. So how does generating new flexible collagen actually resolve something as physically debilitating as stress urinary incontinence?
Well, to understand the resolution, you have to clearly visualize the mechanics of the failure. SUI, particularly the type that plagues postmenopausal women, is rarely a dysfunction of the bladder muscle itself.
Okay, so it's not the bladder's fault.
Usually, no. It is a failure of the floor holding the bladder up, specifically a severe loss of collagen in the pubocervical fascia.
The clinical term for this is urethral hypermotility, right?
Yes.
So picture the urethra as a flexible tube resting on a hammock of connective tissue. When you laugh, cough, sneeze, or jump, the physical pressure inside your abdomen spikes dramatically.
And in a healthy pelvic floor, your urethra gets forcefully squeezed shut against that firm, taut hammock of tissue, which completely stops the flow of urine.
But when you lose that type 3 collagen, the hammock sags, It loses all its tension
Exactly. So when that abdominal pressure spikes, the urethra simply bounces downward into that slack tissue. It hypermobilizes.
because there is no solid backboard to squeeze the tube against.
Right, the valve stays open under pressure and the patient leaks.
Enter the fractional laser. The clinician targets the anterior vaginal wall, specifically focusing up near the urethrovesical junction.
And by triggering the exact cascade, we just walk through the new elastin, the type 3 collagen, the rehydration of the ground substance. The body ends up creating what the medical literature refers to as an autologous mesh.
Autologous simply meaning a structure generated from your own biological tissue, rather than a foreign synthetic material.
Exactly.
So what does this all mean for you listening? Essentially, instead of a surgeon cutting through the vaginal wall, navigating the highly sensitive, complex nerve networks of the pelvis.
Which carries a lot of risk.
Right, and inserting a permanent piece of synthetic plastic mesh to blindly hoist the bladder up, a clinician uses a wand of invisible light to trick your own biology into knitting a custom-fit, perfectly integrated biological mesh out of your own newly synthesized collagen.
If we connect this to the bigger picture of regenerative medicine, the paradigm shift is staggering. This protocol is not masking symptoms.
No, it's fixing the root cause.
Exactly. It is not prescribing a pharmaceutical to dull the nerve signals or putting a localized Band-Aid over a failing system. This is a complete structural reversal. The laser literally alters the biomechanics of the pelvic floor.
It transforms an atrophied, fragile, sagging support wall back into a thick, highly functional support plate.
And the urethra once again has a solid, resilient wall to press against when abdominal pressure spikes.
And because it's an autologous mesh, because it's your own freshly minted tissue, there is zero risk of the body's immune system rejecting a foreign implant.
You completely bypass the chronic inflammation and erosion risks associated with synthetic slings.
Which is massive. But beyond the mechanical fix for incontinence, the clinical data highlights this incredible biological domino effect that occurs as a secondary benefit of this tissue restoration.
Yes, this is fascinating. As the vaginal wall thickens and the architecture normalizes, the epithelial cells naturally begin storing glycogen again.
Glycogen being the primary food source for the localized vaginal microbiome.
Exactly. The healthy bacteria, specifically the lactobacillus strains, they just gorge on that newly available glycogen.
And as a byproduct of consuming it, they produce lactic acid.
Right, and that sudden presence of lactic acid aggressively drops the vaginal pH from an atrophic, highly infection-prone 5.5 all the way back down to a highly protective, healthy 4.7.
So by utilizing a laser to fix a purely structural incontinence problem, the cascading biological response basically accidentally cures the recurrent urinary tract infections and the severe bacterial dysbiosis that plagues so many menopausal patients.
It perfectly illustrates the absolute interconnectedness of human tissue systems. You cannot isolate mechanical structure from cellular function or from the local microbiome.
No, you really can't. By restoring the tensile strength of the foundational scaffolding, you give the entire local ecosystem the precise environment it needs to regulate itself.
And it is achieved entirely through the body's own innate healing cascade, simply nudged in the precise molecular direction by a highly calibrated physical stimulus.
It is genuinely remarkable to step back and look at the entire chain of events. We started this deep dive looking at a 10,600 nanometer light wave that we cannot even see.
And we watched it convert into thermal energy to microboil specific pockets of intracellular water.
We tracked the physical snapping of the degraded collagen helices, the immediate 25% tissue shrinkage, and the localized distress flare sounded by heat shock protein 47.
We watched the vascular system lay down new plumbing so the fibroblasts could arrive and pour fresh, youthful type 3 collagen.
And finally, we saw the creation of a natural internal urethral sling that stops mechanical incontinence in its tracks while simultaneously rebalancing the entire microbiome.
It really forces a necessary reevaluation of how we categorize medical tools. The boundary between aesthetic dermatology and functional internal medicine is far more porous than traditional medical silos would suggest.
It really is. Which leaves me with a final thought I want to throw out to you, the listener. It is a concept heavily implied by the history of this specific technology. Microablative fractional carbon dioxide lasers are not a new invention.
Not at all. They have been utilized in dermatology clinics for over 40 years.
Right. For 4 decades, dermatologists have relied on this exact same mechanism, selective photothermolysis, the Joule effect, the fibroblast cascade to fade superficial tattoos, smooth out severe acne scars, and tighten the sagging skin on our faces.
It took decades for the broader medical establishment to realize that this cosmetic vanity technology could be utilized internally to rebuild failing structural fascia, restore organ support, and provide a functional cure for incontinence.
So it begs the question, what other supposedly superficial treatments, what other pieces of technology currently sitting quietly in cosmetic clinics or physical therapy offices are we completely overlooking right now? What else might hold the key to regenerating our deepest internal organs, allowing us to avoid the scalpel entirely, simply by reminding our aging tissues exactly how to heal themselves? Think about that the next time someone tells you a complex medical problem requires a purely mechanical surgical fix. The entire blueprint for repair might already be sitting dormant inside you, just waiting for the right invisible signal to get to work.